Right. Hello all. Let's get this show on the road. Welcome. Thank you all for joining this webinar. My name's Oliver Anglin. I'm a GP and I'm the clinical lead for children's asthma for the Healthy London Partnership, and I chair the London Asthma Leadership and Innovation Group. Today I'm joined by Julia Moody and Ren Lawler, and we're going to be talking about the role of primary care in supporting children, young people and their families with asthma. So without further ado, let's get on. Chris or Georgie, would you mind sharing your screen for the slides, please? Thanks, Chris. So if we could have our first slide. So a little bit of housekeeping first of all. I'm sure we're all used to online etiquette for now, but just go through the usual. If you could please ensure that you are muted unless you're actually speaking, and can we also ask you to keep your cameras off as well? It's just to preserve bandwidth for the webinar. Obviously, do feel free to put your camera on if you are speaking, but otherwise, please mute and camera off for the rest of the time. There will be an opportunity for a kind of question and answer session, but we're going to do it all at the end of the webinar. So after the presentations. If you do have a question, you've got a couple of options. You can either raise your hand, and we will pick off the raised hands for questions at the end. Also, you can enter your question in the chat box if you would prefer to just do it that way. And then we will pick out those questions and put them to Ren and Julia and myself at the end. So that's for the questions. Just to let you know, we are going to record the session. A link will be available on the HLP website, so you can share this with colleagues or come back to it in the future. And just as a kind of reminder, a big part of why we're doing this is to raise awareness, and obviously raising awareness is critical. We all can play a role in that. So if you are somebody who is on social media, we'd ask you to tweet about the webinar. We'd ask you to tweet about the campaign broadly, and if you could use the hashtag #AskAboutAsthma. Just to continue to generate that awareness across the capital of the campaign and the importance of this really crucial long-term condition. So if we move on to the next slide, this is just our agenda for the webinar. I'm not going to talk too much, just wanted to a little bit of context setting, and then we'll hear from our other speakers. Ren and Julia will cover their areas. Next slide, please. So the Ask About Asthma campaign, this is, we're trying to keep it simple. There's so many different elements to asthma, and there's a huge amount of work that's being done across London around this. But when it comes to the campaign, we've tried to keep it, the intention is to keep it simple. Three key points. Three asks that children and families should be asking for, and that clinicians and other professionals that work with children should be aware of. Three key basic things that really will make a difference. So, do they have an asthma management plan? Are they able to use their inhalers effectively? And have they had at least an annual review, if not more frequently than that? So, remains a critical and crucial condition for children and young people. To give you a bit of a sense, we have over 200,000 children and young people living with asthma in London at the moment, and the primary care really is an area that, from the clinical perspective, will be dealing with a huge amount of that kind of a pyramid of children. So obviously vast numbers at the bottom with sort of lower level conditions that are supported, and those kind of really severely poorly controlled or severe asthma on biologics up at the top. A huge amount of the work is done through primary care, and And that's why we wanted to have this webinar and to talk about that today. So broadly, the key roles within primary care for children and young people with asthma. This importance, typically primary care is the first point of contact where either child has symptoms or parent is concerned that their child might have asthma. So we have this key role in that initial conversation, initial identification, and making a diagnosis. And we'll go into how primary care can go about doing that. We also have a critical role in education for patients and parents. And again, not something that can be underestimated. Typically, even in my day-to-day work, I see patients who have had asthma for years and years, and I ask them if they understand what their inhalers do, and the answer is no, they don't. So, any contact is an opportunity to increase knowledge for children and parents. Primary care has a key role in the regular reviews. We have our asthma registries. So we are best placed to be able to identify children on our registries and to ensure that we are seeing them at least annually. The kind of key, sort of couple of other key issues around these regular reviews. Firstly, is the importance of time. A 10-minute appointment isn't long enough for an asthma review. To do an asthma review well, you do need to spend more time dedicated to it. So that's a key part, and we can talk about incentive schemes, etc., that are available in certain parts of London to ensure that we get these extended reviews in primary care. Also, there's no point doing a review if you don't know what you're looking for and taking appropriate action. So to identify that a child is underusing their inhaled corticosteroids, overusing their SABAs, but then to do nothing about it sort of is a mistake. It's a missed opportunity, and it's putting that child at risk. We have an important role in post-exacerbation reviews. This still is not something that's kind of as widely done as we would like to see. That frequently, too often, there's a sort of treat and forget. So there's a couple of reasons. First of all, an exacerbation needs to be followed up a couple of days later just to ensure that we're seeing progress, because these children remain at risk until they have resolved. The second thing is that an exacerbation suggests poor control, and there's absolutely essential that this is always highlighted. There is no such thing as kind of treat and forget when you've seen a child with an asthma exacerbation, whether that's in primary care and managed through primary care or an ED attendance or admission. Primary care also has a role in identifying high-risk patients. Again, this comes back to the registry, the fact that we have a list of children with asthma within our population. So we are best placed to be able to work through that list and understand where there may be higher risk, and how we go about doing that through data and searches, etc. Again, work in progress to find really good tools, but this sits really well with primary care, and is something that needs to continue to be developed. And the last kind of key point that underlines all of this is around this issue about appropriately trained staff. The data around asthma deaths, etc., frequently underlines the importance of having appropriately trained staff. Having that knowledge, having a good level of knowledge and awareness, whether you're a GP, a practice nurse, our community asthma nurses, our paediatric consultant colleagues with an interest in asthma. Obviously, the amount of training and knowledge you need will be different depending on the type of child that you're looking after. But there is this absolutely key need to ensure that anybody who is treating or supporting a child or family where there is a diagnosis of asthma has the skill set and the knowledge to manage that child appropriately. And we can talk again, if that comes up in questions, about what does that mean and what can we do about it. So that's, I think, to set the context, give everyone a bit of a sense of what we are talking about here today. I don't think we're not getting into the nitty gritty here. This isn't an education session to teach you about the detail of you know, which asthma inhaler to use in which occasion. It's not about that. It's more broadly about this kind of role and function of primary care and supporting. So if there are kind of issues or questions that come up about that, we're likely just to signpost you to other areas where you can pick up that information. So yeah, so with that in mind, I would like to hand over to Ren, who's now going to talk you through some key elements around diagnosis and management. So Ren, over to you.
Thank you. Good afternoon, everybody. I'm just sharing my screen now. Let's do this. Okay, I'm going to assume that everybody can see this unless I'm told otherwise. Okay. Good afternoon. My name is Ren Lawler. I work as an advanced nurse practitioner in South East London, and I work as a senior lecturer at the University of Greenwich as well. I also sit on the Executive Committee and Education Committee for Primary Care Respiratory Society as well. I was just going to move through these now. Okay, so first thing I want to talk about a little bit is about diagnosis. And actually, as Oliver has already said, you know, in primary care, we are best placed in a way to identify patients who may be living with asthma without a diagnosis. But equally, it's important for us to look at those patients that do have a diagnosis of asthma and to question that diagnosis as well. We know that there's an awful lot of people who are not diagnosed, but there's also an awful lot of people who may have an incorrect diagnosis, or perhaps one that is a historical diagnosis, certainly from childhood, from very young, where they may have been, you know, provided a blue inhaler because they're a wheezy child or something along those lines, and then this diagnosis has kind of just followed on from that, perhaps without any real kind of history-taking consideration or investigation either. So certainly within primary care, within the patients that you already have on your list, those that you're already seeing perhaps regularly, maybe it's that the diagnosis doesn't really fit, or it's not marrying up. And so what I would say certainly is that it's okay to question that diagnosis, and that might work either way, as I said. Review the symptoms. So think about the symptoms, think about what we already know to be true about asthma, and see where that individual, where that patient, that child, that young person sits within those symptoms. It's really important with younger people, and actually with adults as well, really, that we think about their experience of asthma. So what asthma means to them, how they experience it, what it is they're actually feeling. And the reason I say that is because often we will use terminology that's familiar to us. So we'll talk about wheezing, we'll talk about breathlessness, chest tightness and cough, as the guidelines will kind of dictate to us. But we also know with children that they will describe things differently. So sometimes it's helpful actually when talking to them to ask them to use any word that they know, for example, that may describe what it is they're feeling in the playground, or when they're running around, or, you know, when they're lying in bed. And they may use different terminology, and that's quite helpful. The reason I would say that is for two things, really. One, so we are more accurate in our documentation of our communication with our patients, but also when it comes to your asthma management plans, your patients are more likely to be able to follow that plan if it's utilising language that is familiar to them. So there's little point in writing in an asthma management plan, for example, I will increase my brown inhaler or whatever it is when I feel myself wheezing, if that individual doesn't really understand what wheezing is, what it feels like, and what it means to them. If we're using their own language and their own terminology in those plans, then they're more likely to be able to utilise them more effectively. So clinical features then that increase the probability of asthma. I'm sure you are all very familiar with these, but again, you know, we're talking about not just making a diagnosis, but potentially questioning a diagnosis. And so just kind of thinking about these a little bit more and getting it in the front of our minds can be quite helpful. Certainly we want to question family history, not just of asthma, but of atopic disorders as well. So do be mindful of the fact that there may, you know, if you're questioning about family history of asthma, you may get a no, or a, you know, not that we're aware of, or something like that. However, it may be that mum and dad and grandparents and brothers and sisters have all got quite significant hay fever, for example, and suffer with eczema as well. And we know obviously that there is a relationship between those kind of atopic disorders and the development of asthma as well. So we're thinking along the lines of probability at this stage, and what kind of things might increase the probability of that child, that individual, having asthma over something else. We want to think about symptoms that are frequent and recurrent, and that's really important in children. We want to think about them being frequent and recurrent, and we want to think about them also experiencing those symptoms outside of times when they know they're unwell. Children will get multiple upper respiratory tract infections throughout the year, more so obviously in the winter months, that may or may not present in a similar way in terms of cough, wheeze, and that kind of thing. If they're having symptoms only at those times when they have an illness or a viral illness or something, a cough or a cold, then that's going to reduce the probability of it being asthma. We would expect them to have symptoms outside of those periods of illness if it's asthma. So those sort of questions can be quite helpful when you're making a diagnosis or questioning one. Other end of the spectrum, then we've got things that lower the probability of asthma, as I've said, symptoms with colds only, isolated cough in absence of wheeze or difficulty in breathing. Again, I would say just be mindful about using wheeze or difficulty breathing in isolation as descriptive terminology, because patients may not understand what you mean by that, and for children it may be getting out of breath or not being able to catch their breath when they're out on the football pitch, or something that's more familiar to them. And on that, I would say it's really important to remember to actually speak to the child themselves. So there's always a risk that the parent will be more forthcoming with the history and sort of say, that they have noticed that the child is more out of breath or something like that. So it's helpful if the child is able to articulate what it is they're feeling, that we have that discussion with them as well, certainly with your teenagers and your older kids. Normal peak flow or spirometry, obviously we're not doing spirometry at the moment, but normal peak flow or spirometry, when they are complaining of being symptomatic, it's going to lower the probability. It doesn't rule it out, but it lowers the probability. And then, of course, your lack of response to any sort of trial of treatment and things like that as well. Off the back of that, then, reasons to have a low threshold for referral to specialist in your kids who are presenting with any of these kind of symptoms as well. These would be unusual with a simple sort of, I say simple, but a simple asthma diagnosis. So any child that is experiencing a persistent wet or productive cough, for example, any family history of unusual chest disease, failure to thrive, as well. And then as you work down, you can see any unexpected clinical sort of signs, and again, not responding to treatment that we would expect some level of response to as well, taking into consideration obviously those possible gastrointestinal influences on symptoms as well. So those are the sort of symptoms that you really would be wanting to get a second opinion for. And it may be that they have experienced some of these symptoms and that has been put down to their asthma in the past. And that's why it's so important to review a diagnosis, even when one has been made sort of historically. Other kind of things to think about then in terms of additional diagnoses. Now, I'm not saying that that someone doesn't have asthma, say they do, but perhaps you are treating them with inhaled corticosteroids, you're treating them as per guidance. They may be on montelukast or something like that, and they just don't seem to be improving or getting any better. And it's important at this point to sort of take a step back. So instead of increasing inhaled corticosteroids or adding in more therapies and things like that, just have a think about those additional diagnoses that perhaps are being undermanaged and maybe having or a sort of impact on your patient's symptoms. We know that for atopic patients, those with allergic rhinitis, for example, or non-allergic rhinitis, it may be that if you can optimize the management of their rhinitis, then you will get an overall better control of their asthma without needing to increase their inhaled corticosteroids. Certainly in your teenagers, we need to think about BMI, we need to think about obesity, overall fitness. There may be a sort of misunderstanding in terms of your patient not doing too well at PE because of their asthma, when actually it may be due to a lack of fitness or obesity or something along those lines. So do be thinking of your additional diagnoses. You may have teenagers. Yep.
Ren, sorry to jump in, just keeping a time check. I know how many slides you've got left, and you've just gone over 10 minutes. So just
that's fine. Yeah. Okay. Thank you. And certainly with your teenage girls as well, you may see some hormonal disturbances. So looking at those kind of things as well, being a little bit more holistic. I won't spend too long on this. Obviously, this is taken from your BTS sign guidelines. The reason really for putting this in is to identify and to remind those probabilities. So we have high probability, we have intermediate, and we have low. And the helpful thing about this is it allows you to hold back a little bit for a diagnosis if you want to consider sort of suspected asthma as a problem that's going to go on the patient's records, but at the same time it's not going to interfere with your quaff numbers and those kind of things, which I know is important to some. So it gives you options for investigations that may be available to you. You can't access in your area, things like Pheno and things like that. If you are using peak flow, then it's helpful to actually understand the algorithm that can enable you to work out that variability. So certainly if you can get your parent, your child to do the peak flow at least sort of 4 times a day over a longer period of time than 2 weeks, then you get a much better picture of what their variability might be. And obviously working out the average there from the mean values is sort of the way that you would want to think about it, as opposed to just looking for that kind of toothy graph. So let's say it is asthma, that's wonderful. We want to perform a structured review. There's a SIMPLES framework, the reference is at the bottom there, that asks you to think about smoking, inhaler technique, monitoring, pharmacotherapy, lifestyle education and support. Smoking, very important in your teenagers. Difficult conversation to have probably when either mum, dad or carer are present as well, but it is something that's worth sort of mentioning. Even if they deny smoking in front of parents, you know, you can still give very brief advice just in case they happen to think of starting to smoke, that kind of thing. And if they are honest about their smoking, obviously thinking about cannabis use and stuff as well. I won't go too much into that because obviously it's a difficult conversation, but it's something that shouldn't be ignored just because they're younger. Inhaler technique and monitoring pharmacotherapy and things like that all start coming under the same thing. For the sake of today, I'm just going to have a quick look at inhaler technique and education. Interesting piece of research about teenage compliance. You know, we very much talk about dexterity and inhaler device choices and things. In the elderly, there's a lot of research on it. But actually, this particular piece of qualitative data has demonstrated that with teenagers, you need to be thinking about whether or not the inhaler and the device you're giving them is portable. Shape of certain inhaler types, so certainly turbo inhalers and things for teenage boys, putting them in their pockets can sometimes look like something else, is how I would word it. You can work that out for yourself, I'm sure. So there's certain types and shapes that they don't want to use, and then personal or peer preference. So very much having that conversation with sort of teenagers and things about, you know, what sort of one looks cool, what it looks like, and you can use external resources for this. So Right Breathe, for example, so you can show them pictures of what the device will look like, may help to increase the compliance within that sort of age group. And in between, thinking about maintaining technique between reviews, the sort of things we know that helps, putting labels on inhalers, they're a little bit more descriptive about how they use the device, signposting to videos. There's a UK inhaler group, Asthma UK, Right Breathe, there's lots of things there, and utilising your local pharmacist much better as well. You're very well placed within the community to remind people when they collect each prescription. The second thing then, as I said, as part of that Simples framework, is to think about your management plans, and all patients should have one. Unfortunately, we're still not particularly good at doing it, and there's a lot of overthinking as well. We know that written asthma action plans almost halves the risk of hospitalisation, reduces A&E attendances, and is going to improve overall kind of quality of life as well. A lot of the time people get a little bit caught up in what it needs to look like. They feel that they need to put lots and lots of information into it, and actually it's really not like that. The point about these is that they're individualized and that they're personalized as well. So you need to be using your individual patient's experience of their condition to write this. If you write it for them, without engaging them in it, they won't use it. It's as simple as that. So using details from their experience is really important, using their language, as I said at the beginning, and making it relatively simple or complex depending on their understanding, but remembering that they're probably going to use this when they're deteriorating and feeling unwell. So very, very simple instructions in terms of what they need to do next to keep themselves safe is important. If we give a worked up example then, and you don't have to use all of this, you can use one bit or another bit, depending on your patient's kind of understanding or the parent's understanding. Understanding when their asthma is well controlled. So what does it mean to them when they feel well? How do they describe that? Describing the sort of different stages of when they're getting worse. So I know I'm getting worse when I can't play football with my friends, for example, or I can't do the full 90 minutes, I have to come off at half time. Something that is kind of quite concrete for that individual, and it can be one or two or three things. They might be able to think about time scales. Parents might be a little bit better at doing that. I remember the last time he got unwell was, and this is how it looked. Understanding their sort of how to step up their asthma medicines, and also understanding when to seek help. And for some people that will be quite early on in a deterioration, and other people may have more of an understanding of increase inhaled corticosteroids, contacting the surgery, that sort of stuff. So quite kind of bullet pointed for them. Important to put triggers in there as well. So talk about triggers. They're going to be individual. It's no point just talking about all of the triggers that we know to asthma, because not every single person will be triggered by every single thing. So their understanding of their triggers will increase the probability of them being able to do trigger avoidance, or at the very least, reduce harm. So being aware that hay fever season's coming, and to start their antihistamines early, and all of those kind of things can also be put in an asthma action plan. And the important thing, as I would say, is that it doesn't have to be complicated. You don't have to download a complicated template. It can be written on a sheet of paper. You can send it in an email. I've written it on the white side of a prescription very quickly at times, just to make sure they've got something. Something is going to be better than nothing in terms of their overall control. Put in it about their asthma triggers, what triggers them that they know about. If they tolerate using peak flow and they can understand peak flow, that can be helpful. If they can't understand peak flow and they're not going to understand, 25% reduced, 75%, then don't use it. Talk about triggers, talk about experience, talk about symptoms with them. They should know the names of their medications. A lot of people won't. They may use colours. We've said in the past not to encourage that, and they should know, but actually with kids, it's far easier for them to identify colours and things like that. And then they need to know what they need to do in terms of their asthma attack. And as my final point on this, I would just say it's incredibly important that from the moment a child understands when their asthma is getting worse, that they know what to do. When they're at school, mum and dad or carer won't be there. So as much as it's important for mum and dad to know what to do, so does that child. And that child needs to know how to articulate to teachers, actually, I think this is my asthma and this is what I need to do. Okay. Thank you.
Amazing. Thanks so much for that, Ren. Real kind of whistle through it. Appreciate it. So there's a lot more detail there, but I think that gives us a really sound framework there. So not going to waste any time. We'll move straight on to our next speaker. I'd like to welcome Julia Moody, and over to you, Julia.
Thank you very much, and good afternoon, everybody. My name is, Julia, and I'm a GP in Tower Hamlets, and I'm the clinical lead for Tower Hamlets CCG for children and young people. So I'm not an asthma expert, but what I want to sort of talk about is some of the stuff that we've been doing in Tower Hamlets, working across the whole partnership. So we have an organisation called Tower Hamlets Together, which includes the local authority, includes voluntary sector organisations, of which we have 260 something working with children and young people. And we also have all of our health partners as part of that partnership, and that's been a real strength as we've kind of considered asthma. And before I show you the slides, which I will share, I wanted to tell you about my Monday afternoon, where I had a kind of normal Monday afternoon, as far as normal is at the moment in primary care. And as part of that, I'd booked in 3 young people. And the first one was an 11-year-old whose mum had asked me to book her in because she was anxious, and I noticed that she hadn't had her asthma review, so I was hoping we could talk about that as well. I also noticed that when she saw CAMS recently, she had told them that she wasn't doing her swimming anymore because she couldn't do that because her asthma was so bad. She didn't turn up. I phoned mum because I know her quite well, and she said, yes, she won't talk to you, she won't come, but her asthma's fine. She's hardly using her inhalers at all. So we made a bit of a plan as to what to do next. I carried on with my afternoon, and a bit later on I'd booked in to see a 12-year-old. So I'm not seeing many people face to face, but she needed to be seen. Again, she's someone who had an asthma admission in the last year, and she saw the asthma specialist nurse recently. But she's really struggling with anxiety, and her anxiety seems to be triggering respiratory symptoms. So Ren's comments about the sort of questioning of diagnosis, but particularly the awareness of more than one diagnosis, I think was really significant there. So she didn't turn up, and spoke to mum, and she'd had to call the police because her child hadn't come home the night before, and they're having all sorts of other trouble within that family. And so asthma is just part of their picture in a very primary care kind of way. And we talked about what we would do next, and how we would review her asthma, which clearly needs to be monitored. Carried on with the afternoon, and the third person I booked in is a 15-year-old. She'd had an admission in January with her asthma and had needed IV treatment, was really poorly, and presented then with her mum, who's had asthma all her life and presents as an expert, but didn't realise just how unwell her 15-year-old was. And I know that she has a nebuliser at home, which isn't prescribed, but she has one anyway. And I was able to let tertiary care know about that, because we're really anxious about this 15-year-old and her poor care and the risks that that represents. So that was my Monday afternoon, and I will now share my screen because I think it's about understanding the opportunities we have within primary care to focus on those real issues that we have unique opportunities to speak to. So our journey really with asthma, most recently in Tower Hamlets, was prompted by the tragedy of a 14-year-old boy who'd had asthma for a long time and who also had allergy, and who died as a result of collapsing at school. And this has been the subject of a serious case review, and we've kind of really used that as a challenge to the whole system, to the whole of Tower Hamlets Together, to consider all the aspects of opportunity that we can use, really, so that we can prevent future events like this.
Julia,
we started off by...
Julia, I'm sorry, I don't think we can see your slides.
Oh, sorry. I'll try again. One moment. Okay. Can you see them now?
No, nothing's.
No, Chris, do you want to share yours, and then Julia can just
that'd be great.
say next.
For all the rehearsing, it doesn't always work. We started our work consulting with children.
Unshare
oh,
screen.
Sorry.
That's great. Thanks.
Thank you. We started our work discussing with families and children what they wanted us to do. So if you could move to the next slide, please. And one of the 5-year-olds involved in that consultation drew this picture, and he said, when I have a bad asthma day, it feels like a monster. And we took that to see as really our slogan, can we stop the monster days? These are preventable experiences, they're treatable conditions, and we need to be improving the way we're doing that. And if you have the next slide, please. So the families and children identified some key issues that they thought we needed to address as a system. They experienced a lack of information from healthcare professionals and also conflicting information. So people were giving different advice in the GP setting or in A&E or in the asthma clinic. They also identified air pollution and the impact of that as a concern, and an awareness across the whole system, which needed to be both written and verbally. So in schools, in the GP setting, wherever a child or family found themselves, they wanted a sense that we had shared our understanding of asthma and were speaking about the same thing. And finally, the management in schools, that there needed to be peer support and that there was currently a lack of understanding and awareness of asthma in schools. And next, please. So we set about as a system to reduce our unplanned admissions, the measure we felt we could have an impact on. We set a target of 15%, and this just shows you the different interventions that we used. I'm not going to dwell on any of this, but it included everything from housing to tertiary care. And next slide, please. Working with all of our partners, we managed to reduce our asthma admissions very significantly beyond our ambition. And this included 757 professionals being educated in the system, and all sorts of pilots that didn't work and some that did. And now we're trying to work out where we go next. Next slide, please. So, and the next one. We know that primary care is our next real focus. Next slide, please. We know that we could do better, and what I find when I work in partnership is that I'm always being told how primary care can do better, but there are clear things that we can improve. And next. The first thing that, or one of the most significant things I think we did, was develop some shared guidelines. So these don't hold any surprises, but I think they are amazing, and do use them if you'd like to. I think what it means is that whether you go to school or to your GP or to the pharmacy or to your youth club or to A&E or secondary or tertiary care, you're getting the same message. And I think that's an amazing strength. And these guidelines are very usable. They are sort of practical, useful things. So I'd really encourage you to have a look at those if you'd like to. We're certainly now moving on to our next stage, really, which is really implementing those and making sure that we're using them effectively. Next, please. We have an EMIS template, which we developed. In fact, it was developed initially in Hackney, in our neighbouring borough, and we've pinched it and adapted it slightly. And that self-populates the management plans, which has made things much easier. It also systemises our reviews and also our post-exacerbation reviews in a really helpful way. Next, please. We've got locally network incentive schemes, controversial, and yeah, we can have a whole conversation about those. But one of the things that those have brought into focus is the need for annual asthma reviews. We've managed to increase the number of children that have individual management plans from 40% to 75%. And we then did a case finding network incentive scheme to identify children who are being treated as if they have asthma, but without a diagnosis. And that increased our prevalence from 4 to 5%, which was a first year bit of work, and we're hoping to build on that. We've also got a new incentive scheme, which is around the prescribing of spacers, because we know that those aren't being prescribed very effectively. When we did a review in schools, we found that 60% of children had an age-inappropriate spacer in school. And next, please. We've developed some trigger tools. I say we, this isn't me. This is the Clinical Effectiveness Group, which is part of QMUL, our local academic department. And I don't know whether these are used elsewhere, so I thought I'd show you a picture of what it looks like, and you can see what it means is if you see somebody for any reason, so if you go to the next slide, you have a pop-up in the corner which tells you that they have a high use of SABAs, and so if someone has been issued with more than 12 inhalers in the past 12 months, that alert will pop up. I think that's incredibly helpful. It means we can search for those people and focus on them. And next slide, please. And similarly with management plans, if you move to the next slide. We've systemized that. So again, wherever you pop up in the system, you're offered the same management plan. And on EMIS, that's where we find them. So there's a 0 to 5s, a 6 to 11s, and a adult plan. And they're readily available either from the asthma template or on EMIS as a document. And next slide, please. So we know that 48-hour reviews are important. I've been really encouraged by the research that's was done in Islington, and I know that was presented earlier on in the week, so I'm not going to pinch too many of their slides, but we know that 10% of asthma deaths had an admission in the past month, and Asthma UK, when they looked at asthma admissions, only 26% of people were having reviews within 48 hours. And whilst there wasn't much evidence to support them, Islington have produced some great evidence. So next slide, please. The problem we have with them is that sense of whose job is it, and who knows it needs to be done, what exactly does need to be done, and is there any point anyway? And that's the evidence bit that I'm coming on to, I think, in the next slide. This is the trigger tool that Islington developed, and it's been a way of identifying where children, or particularly children, need to be. So if you go through these questions and you score red, you need to go straight back to ED because your situation is getting worse. If you score amber, then you need a same-day appointment with a clinician, and we think that should be a GP or practice nurse in the surgery. And if you are green, then you're responding well to the treatment and you need to be planned in for your asthma review in 4 weeks' time. And the next slide shows you what a difference it made in Islington, which is that if you did not receive your 48-hour review, you were 2.5 times more likely to reattend A&E, and you were nearly 4 times more likely to be readmitted. And the next slide. So we have taken this and we realised there was an opportunity. So clearly COVID has been a disaster, but one of the things it produced in Tower Hamlets was a monitoring service which the GP Care Group ran. They were monitoring people at home who had significant symptoms, who needed their vital signs and their oxygen saturation monitored by advanced nurse practitioners. And we thought, aha, could this be a way, a system that we could use to include asthma and wheeze, because this service is running 24 hours a day, 7 days a week, not 24 hours a day, and part of the out-of-hours service, which is 24 hours a day. And so we spoke to them, and happily they have accepted this role. So we are now going to be offering our 48-hour reviews, and we're using the same screening tool as has been used in Islington. And we haven't quite launched, but we are just about to. Next slide, please. There are some challenges to doing this, and one of the challenges is you need to know who needs a 48-hour review, and we've had some difficulty in getting a daily list out of the hospital to know who needs to be reviewed. We need to make sure that the training of the advanced nurse practitioners and quality of the monitoring is good, and we discovered some of our nurses weren't confident with children's care, so we're looking at that, and our nurse specialist in asthma has been really helpful at providing training. And that sort of speaks to a wider question, I think, about workforce, which I won't dwell on here, but I think it's a big part of our challenge. And next. So next, we think we do need more training. We think we're developing a locality paediatric model, which has been kind of rumbling along for about 3 years now, but the idea is to provide support within primary care and an opportunity for primary care to meet with a locality paediatrician and acute paediatrician to increase confidence and competence in looking after children in primary care. We're going to be maintaining our paediatric hotline, which is a hotline which GPs use if they think a child doesn't need to attend ED, but does need to be seen within 72 hours, and that is in a rapid access clinic, which has been very helpful. We've also been pushing advice and guidance hard because that's been a real benefit to children not needing to be seen in secondary care, but getting better care within primary care. We're going to be assessing the quality of the reviews, and we wonder where the other 4% is. We know that we should be having a 9% prevalence with children with asthma. We don't know where they are. We know, don't we, on a day-to-day basis that we come across people who are being treated as though they have asthma, but I think we're going to be looking at that as our next challenge. Thank you very much.
Fabulous. Thanks so much for that, Julia. That's really helpful. And for those who are interested in learning more about the Tower Hamlets work, there is a podcast that's available that was recorded, and I think that should be up now. Chris or Georgie, if you could correct me if I'm wrong there, and maybe put the link into that in the chat, so we do have more information about that. So yes, so thank you both. We're going to take some questions. I've got a couple that have come in from the chat. If anyone has further questions or would like to put their hand up, and we'll come to you. So couple of questions from Mark Levy. First one was to Julian. You mentioned group consults in schools. Can you give us any more detail about that, what that looks like, and that is mentioned by Tori as well in that podcast?
Yeah, so this was one of the pilots, and this was one of our most successful pilots. So Tori, our asthma nurse specialist for children, was very much key, if not central, to all of our asthma work. And she piloted a gathering in children's centres of parents and children who wheeze, which didn't go well at all. But one of the teaching assistants from a local primary school said, why don't you come and try it in the primary school? And so the school identified the children on their asthma list and brought them together for an after school session with Tori. So there were teachers, parents and children, and Tori was able to do a group consultation which involved training. It involved training for school. It involved identifying children who were at high risk. And the alarming thing was that I've identified large numbers of children who had neither presented to primary care or anywhere else, but who were scoring very poorly on their asthma control test, and who Tori was then able to intervene. So it's a pilot that we're developing. We're hoping that school nurses will be able to carry out an initial group consultation similar to this, and then identify the high-risk children so that Tori can then do a second session with each of those high-risk groups, rather than her doing the initial sessions, because we want to kind of use her as a valuable resource. And we're not quite there yet, and obviously at the moment everything's a bit up in the air, but it was so successful. We think it's a really key learning opportunity that might well be useful elsewhere.
Thanks, Julia, and obviously the importance of that then linking back in through primary care and working as a system to make sure those kind of communication channels are there as well. Another question or comment from Mark was around a couple of things relating to the Tower Hamlet plan, which there is some significant discussion around at the moment. This is the weaning plans and the use of salbutamol weaning plans, and the use of dexamethasone within the hospitals as an alternative to prednisolone. Do you mind if I field this initially, Julia? I think just for the setting of context, I think Mark raises a really important point here, which is around the fact that salbutamol is there are pros and cons to weaning plans and using high dose. You know, it's nice for parents to have something written down. It's really quite helpful for them to have something that they can follow, like with a written plan. So there's some real pros and a real sense that there's an advantage to doing that. There are disadvantages to using weaning plans as well. So you're using whacking doses of salbutamol. There can be over-reliance on that. There's issues about down-regulation of beta agonists when you're using high doses of salbutamol, which may make it less effective. So I think rather than getting into the full debate now, I think the absolute essential thing to highlight to people is that there are risks with using a written weaning plan using those high doses, and you need to be really sure you know what you're doing if you're going to use one of those. And if you're not really comfortable with it, the important thing to think about would be explaining to parents the use of salbutamol on a 4-hourly basis, a number of puffs as appropriate on a 4-hourly basis, and if that isn't working and they're needing something that's not lasting 4 hours, that they need to seek attention. And I think that if you're not comfortable with prescribing really high doses and being absolutely certain that that is safe for the people you're talking to, then going for something at that level is more appropriate. And we do need to make sure there's consistency. It is so, you know, Mark, I'm very aware of conversations we've had before about this. We do need to make sure there's consistency and understanding about what that looks like for London, and will continue. But in the short term, it was just to flag that up to people. They're not a panacea. You need to be very careful when you're using weaning plans. They have to be used appropriately and within the levels of your expertise. And the other thing around the dexamethasone as well, Mark, I'm not going to get into the detail of that here. I do think that's a really important point. You know, the specifics of which medications we should be using is probably outside the scope of this particular webinar. But I think again, just to flag to people that you know, there is a bit of a difference between what is being prescribed in acutes. The idea of using dexamethasone rather than prednisolone in the hospitals, it's, you know, there's some inconsistency across London, and there needs to, you know, that is certainly something that needs to be looked at with the expertise shared, but not directly relevant to the subject here. But just to flag that to people that is an issue we need to be aware of and to be cautious around. There was another question. Ren mentioned in her talk about the role of that pharmacists can play. Is there anything that, Julie, you from your experience, that you think there might be ways in which primary care could work more closely with pharmacy, or we could engage our pharmacy colleagues?
Yes, I think this is something we've really got to build on. I went to one network meeting within Tower Hamlets where the GP practices had got together representatives from every community pharmacy in their network, and they had a joint meeting looking particularly at inhalers from an environmental perspective, but also an opportunity to talk about the training opportunity there is. I think we need to build those relationships. We're still working at it. That's certainly not something that's working across the whole of Tower Hamlets yet, but there is a willingness, and I think we just recognise that pharmacists are key. They as Ren pointed out, they are dispensing. They're seeing people with asthma far more often than we are, and quite often now I will send the pharmacist a message as I issue an asthma medication, particularly if I'm aware that person is overdue for a review or is overusing their medication. I think we can build that working relationship with real benefit. Oliver,
you're still on mute, Oliver.
Oh, sorry. Thanks, Julia. Yeah, no, I was just going to see if Ren had any thoughts on that as well.
Just to echo what Julia said, to be honest with you, I mean, I think, you know, the way we are in primary care at the moment, it's really important to think about the other people that are involved in care. You know, we're seeing paramedic practitioners now that are working within primary care, you know, pharmacists, physios, all different kind of disciplines. And I think it's quite important that we recognise that and see the value that different disciplines and the objectivity that different disciplines can bring to patient care.
Okay, that's thanks, Ren, and I, you know, would certainly echo the thoughts of both. Just checking, we have okay, so a question in the chat. I have a mother coming with her 5-year-old to see me next week. GP provided peak flow meter, which mother is struggling to get her daughter to do. She has responded well to Montelukast. I've agreed to see, as PNs have continue to see patients. My question is how best to confirm the diagnosis. So, yeah, I mean, a really interesting one. Ren, do you want to, I'm just kind of conscious of time here. Ren, do you want to just quickly pick that up?
Can you just repeat the last bit, Oliver, because I couldn't hear it, sorry.
Okay, yeah, so a child responding to Montelukast, 5-year-old, responding to Montelukast, can't do peak flow monitoring, and questions about how you confirm diagnosis in a 5-year-old child with suspected asthma. I think without going into the detail there, Ren, what would be your suggestion?
I think my suggestion is certainly around young ages like that, I would always be a little bit more mindful. We know that Montelukast can have a positive effect on atopy as well. So, you know, the improvement may, you know, potentially be secondary to a sort of rhinitis and various other things as well. For me personally, just speaking as myself, I would probably keep them on the register as suspected asthma for now, and would monitor quite closely with a sort of management plan, with close interaction with parents or carers, and see sort of where they are in their understanding. I think historically we rush to make a diagnosis, and patients want a diagnosis because it makes them feel better to know what it is they're dealing with. But I think at very young ages, or when there's any kind of possibility of it being something else other than asthma, then it's kind of safer to do your watchful waiting and ensure that that parent, that family are supported, and that they understand this isn't a case of us saying we don't know. This is a case of us saying it could be this, but we want to be 100% sure, and we're going to be more sure the longer we leave it and the longer we watch it.
That's great. Thanks, Ren. And I think so. I'd say to Francis, with your chat, I think certainly there are asthma consultants, and a lot of areas have specialist community asthma nurses who would all be very happy to have a conversation with you about this without you needing to without having to wait for a referral. So I'd certainly encourage you to get in touch with them. Get in touch with your local experts if you have any doubts about it. I suppose an important thing to bear in mind, again, just as a reminder, there's no definitive test for asthma. And I think in primary care, we sometimes feel like if we send them somewhere else, somebody will do a test that will prove 100% yes or no. The reality is that doesn't exist. And this is why very much we work following the BTS sign guidelines are quite helpful about talking about the probability of asthma and working to that effect. So, you know, we do like a nice cutoff as GPs. You know, we know what a hypertension is. We've got a set fixed number for COPD. It's not like that for asthma. It is balance of probability, and why it's important that you feel qualified to make decisions like that, or that you're talking to somebody who can talk you through that. And that doesn't necessarily mean referring to secondary care for a special asthma test. Right. Okay. Sorry. Now, it's a huge topic, lots of stuff that we could keep talking about, but we have come to the end of the hour. I hope this has given you a bit of a flavour, and particularly, you know, around diagnostics, the role of primary care, how things can be done across the system. You know, the work on incentive schemes, extended asthma reviews, the importance of technology in developing EMIS templates, links in with secondary care, the role of community asthma nurses. There's a huge amount here that can link into and feed into primary care. If you all areas are doing work on this. So all areas are doing work on this. If you are interested in something that you've heard, it is possible to track down who your local person to speak to is. We can put you in touch with them. If you don't know directly, you can link in to us through HLP, and we'll put you in touch with your local point of contact who will be able to give you more information on that. Mark, Mark flagged something about some concerns around Montelukast. So if you just check the chat, there are a couple. You have to be careful a little bit with Montelukast. There are some safety concerns, and there are some issues around prescribing. Just to be aware of it. It's not a reason not to do it, but Mark has flagged that. Right. Sorry, I'm kind of getting messages in different places as well. There was one more question from Chris. I think we'll just for purposes of time, Chris, I don't think we'll be able to pick that up just now. So it's being aware, looking at what's available to us, remembering the significant role that primary care has to play, and depending on where you work in the system, I hope we've given you some ideas of things to think about where you can apply some of this. So, you know, if you're just working within practice, what can you do within your practice? If you have a position as a community asthma nurse, or you have a role within a PCN, again, looking at how you can adapt practice across your organisation or your group of organisations to improve outcomes with that primary care focus. I think that's it for today. I'd like to thank you all for coming. There is before you leave, if you wouldn't mind please clicking the link for the feedback, the feedback survey. Really, really useful. I think running this campaign is hugely important for the children, and young people with asthma. HLP puts it on every year. The work that we do and our continued work isn't guaranteed. Running things like this, if we're able to demonstrate value, increases the chances of being able to continue to do it. So it's really appreciated if you could take some time to go through the survey and just answer some questions for us, which would be really useful. Yeah, so that's it. Just to wrap up, thank you all for coming. Remember to use the hashtag #AskAboutAsthma. It's all about raising awareness this week. So do please continue to fight the good fight, put the message out there. If anything has interested you, you want to get in contact from anything we've discussed, please do contact the team at HLP. A huge thank you to Julia and to Ren. Your time is much appreciated. Thank you for coming on and sharing your expertise. Look forward to seeing you both again in the flesh at some point soon. And with that, thank you all. We will wrap up.
Thanks very much, Oliver.
Thank you.